Hello, everyone, and welcome to this lecture on peripheral neuropathy. My name is Dr. Fetsi Mushi to present this particular topic. So this is the outline of our presentation today. We'll look at an introduction of what peripheral neuropathy is, how to classify peripheral neuropathy, which can be in different ways, and then we'll discuss a few clues to diagnosis of peripheral neuropathy, as well as investigations and treatments that are available. So peripheral neuropathy is generally a term that is used for damage to the nerves of the peripheral nervous system. And this can be caused by diseases of the nerve itself or from side effects of systemic illnesses, of which there's a wide variety of illnesses that can cause damage to the nerves of the peripheral system. And it's important to remind ourselves that the peripheral nervous system is actually a subdivision of the nervous system that contains all the nerves outside the central nervous system. So we know that when we are dividing this nervous system, its broad classification, or rather broad division, is into the central nervous system, which is made of the brain and the spinal cord. And then we have a component of the nervous system that is outside the central nervous system, and this is what is referred to as the peripheral nervous system. And it's largely contains of nerves that connect the central nervous system to various organs of the body, limbs, as well as the skin. So the nerves that are found in the peripheral nervous system come in actually different sizes. Most of them, we have the motor nerves that are mostly myelinated, and then and these are the large sized nerves. Then we have slightly smaller sized nerves than the motor nerves that are the sensory nerves, and these ones can be myelinated or demyelinated. And then the smallest size of nerves that are found in the peripheral nervous system are those of the autonomic nerves, and most of them are actually unmyelinated, but you can have a few autonomic nerves that are lightly myelinated, so that should be myelinated. So it's important for us to know the different types of nerve fibers because they can help us classify different types of peripheral neuropathy, but they can also help us know what the cause is or the pathophysiology that brings about the peripheral neuropathy that an individual might have. So these myelinated fibers, they allow for rapid transmission of impulses. And so we find that nerves that are myelinated tend to have a quick transmission of impulses across them. The peripheral nerves are not as protected as the nerves of the central nervous system, and as a result, they are susceptible to a variety of toxic, infectious, or metabolic injury, and that's how come they are prone to having various injury that result in a peripheral neuropathy. In terms of epidemiology, peripheral neuropathy affects approximately 2 to 8% of adults, and the incidence actually increases with the increasing age. So the older someone is, the more likely that they are to have peripheral neuropathy. And then also as a reminder to all of us that the peripheral nervous system is actually composed of 10 pairs of cranial nerves as well as 31 pairs of spinal nerves. A lot of times people tend to forget that actually cranial nerves also have a component that is a part of the peripheral nervous system, excluding the first two cranial nerves, which is the olfactory and the optic nerve. However, from the 3rd to the 12th cranial nerve, they do have a component that is in the peripheral nervous system. And then for the spinal nerves, we do know that all the 31 pairs actually do have a component as well for the peripheral nervous system. And like I mentioned, cranial nerves 3 to 12, they do share some compositions of spinal nerves. And so any pathology that will involve the peripheral nervous system can also affect cranial nerve 3 to 12 as well. This is a diagram that just shows the different, all the 12 cranial nerves, and the ones that we are saying can be affected in peripheral neuropathy are from 3 up to all the way up to 12, and it actually shows the different parts of the face and neck as well as the other parts of the body organs that the cranial nerves innervate. And this diagram shows the 31 spinal nerves that we discussed. So we've already discussed the three types of nerves that are found in the peripheral nervous system, and it's important to note that each type of nerve has its own specific function. So the motor nerves that we talked about are the largest types of nerves, and these control voluntary skeletal and somatic muscles of the body. And then we have sensory nerves, which are slightly smaller than the motor nerves, and these ones, they pass on sensations such as cold, heat, pain, from the affected area of the body to the brain. And then finally, the smallest types of nerves are those of the autonomic nerves that help to regulate the automatic functions of the body, such as blood pressure, bladder functions, sweat levels, just to mention but a few. It's also important for us to be able to identify what the pattern is for an upper motor neuron lesion versus a lower motor neuron lesion. This is important because when it comes to peripheral neuropathy, most of the manifestations are actually those of a lower motor neuron pattern. And so when you are approaching a patient with any nervous system problem, one of the things that you want to make sure you have in place is to know whether the features that the patient is presenting with are those of an upper motor neuron lesion or a lower motor neuron lesion. So when it comes to peripheral neuropathy, most of the patterns that we tend to see, or the pattern that we tend to see in most of the cases, is actually that of lower motor neuron features. So you find that they have a low tone, they may present with a hypotonia, and the bulk is that is reduced, so they will have atrophy. So they may have also fasciculations, but not in all the cases. And then the pattern of weakness that usually is noted in peripheral neuropathy is that of distal being weaker than proximal in most of the cases. And then in terms of reflexes, they might be absent or reduced, and the Babinski or the plantars are usually downgoing. When it comes to classifying peripheral neuropathy, there are various ways in which peripheral neuropathy can be classified. And so this slide in particular shows the different ways that peripheral neuropathy can be classified. So this can be based on the number of nerves that are affected. It can also be based on the type of nerve fibers that are affected, also the process that is affecting the nerve, which is also referred to as anatomical classification, whether it's demyelinating or axonal. And you can also have an etiological classification that is based on the cause of the peripheral neuropathy. And then finally, you can also classify it on the time course, whether it's of acute onset, subacute, or it's of a chronic onset. So we'll go through these different classifications, see how peripheral neuropathy can be classified, and tied to each of these classifications will also be different etiological causes of the neuropathy. So in terms of the number of nerves affected, there are mostly three ways that you can classify it. So you can have a mononeuropathy, in which only a single nerve is affected. You can also have what is called a mononeuritis multiplex, where you have different individual nerves that are affected at different sites. And this can happen simultaneously, or they can happen at different times. And then you also have a polyneuropathy, which I think is one of the commonest form of neuropathy that we see in terms of pattern. And usually this one describes a diffuse symmetrical disease, and usually commences in periphery. So just to delve in a little bit more in detail of this, in this particular classification. So for a mononeuropathy, we said there's focal involvement of a single nerve, and usually the presentation is that of weakness and sensory loss in the territory of the single peripheral nerve that is involved. Oftentimes, patients usually have pain along the path of the nerve, and it's the most common cause of a mononeuropathy is by physical compression of the nerve, and this is usually called compression neuropathy. And this can be due to different causes such as direct trauma, entrapment, neoplasms, or compression due to other things like vascular lesion. So this table just shows some common mononeuropathies that you can come across. It describes the particular single nerve that is involved, as well as the compression site. So I think one of the common mononeuropathies that we see in practice is that of the median nerve, where the entrapment or the compression site is at the carpal tunnel at the area of the wrist. But you can also have involvement of the ulna, where you have entrapment at the cubital tunnel, or that's at the elbow. You can have also at the radial nerve, mononeuropathy at the spiral roof of the humerus, as well as the others that are listed in this particular table that you can actually go through in your own time. And then when we talk of mononeuritis multiplex, so we mentioned that this is a simultaneous or sequential involvement of individual non-contiguous nerve trunks. So they will not be in the same region, they will be in different regions. And so they typically present with either an acute or subacute loss of sensory and motor function of individual peripheral nerves, but in different areas. This may or may not be painful, and also the patient can have an isolated reflex loss. This slide only shows the common causes of a mononeuritis multiplex, or conditions that can actually cause a mononeuritis multiplex, as indicated, including diabetes mellitus, infections such as leprosy. You can also have vasculitis and other inflammatory conditions like sarcoidosis. You can also have malignancy as well as HIV infections. And then when we talk of polyneuropathy, so this term is sometimes used loosely to actually refer, rather interchangeably used with the term peripheral neuropathy. So many times people use the term peripheral neuropathy when what they actually mean is that the patient has a polyneuropathy. And polyneuropathy will take a course that might be acute, it might be chronic, it might also be static or progressive, relapsing or towards recovery, meaning the patient might actually begin to improve during the course of the illness. And most cases of a peripheral neuropathy affect the sensory and the motor nerves. Most cases of actually a polyneuropathy, but they can also affect the autonomic nerves as well. In polyneuropathy, there's a widespread loss of tendon reflexes, which is very typical. And the pattern of weakness that usually occurs in the polyneuropathy is that of distal weakness, as well as distal sensory loss. And the reason is that the causes of a polyneuropathy will actually affect the nerves that are the longest nerves. And these are the ones that usually come to our distal parts of our limbs, that is the legs, and as well as the hands. And so the pattern of weakness and sensory loss is in such a way that the feet are affected usually first, and then in an ascending manner. And when you have peripheral or polyneuropathy up to the level of the knees, it's expected that then the hands get involved. And with polyneuropathy, it's usually symmetrical. So when you have involvement of the feet, you find that it's both the left and the right, as well as when you have involvement of the hands, it's on both sides. So of notice that it's actually symmetrical as opposed to the other types of neuropathy that we have earlier described. So I mentioned that the longest fibers are affected first, so usually symptoms develop in the extremities of the body, such as the feet, the legs, and the arms. So this diagram just sort of emphasizes what we discussed earlier in terms of what a mononeuropathy is. So on your far left, you're able to see an image that depicts what a mononeuropathy would look like, and that is like a single nerve that is affected. So the part of which is red shows the area that is actually affected, and then so you have a mononeuropathy, you have a polyneuropathy like we described, that is is symmetrical and usually starting distally. So in this case, the feet and the part of the legs, as well as the hands and the forearms are involved. And then you have your mononeuropathy multiplex, where it is in non-contiguous areas. So on the upper limbs, you have involvement of the right upper extremity, and then in the lower limbs, you have the left lower extremity involved, and then you also have parts of the right lower limb are also being involved. So you have these different regions that are involved in terms of the neuropathy. And then I thought it should also be important for us to discuss a few more definitions of terms that we might encounter when in practice when we are dealing with patients that have peripheral neuropathy, and one of them is for us to understand what a radiculopathy is. So when we discuss a radiculopathy, this is injury or damage to the nerve roots, and it causes sensation deficiency in a specific dermatome. And when weakness also occurs, it's also in a specific myotome. And a radiculopathy can be either a monoradiculopathy, where root diseases occur by disease of the spinal column and a specific spinal column, and there's changes in the distribution of a specific spinal nerve root. And then you can also have a polyradiculopathy, where there's disease of multiple peripheral nerve roots. This is usually asymmetric and there's an erratic distribution, mostly in proximal, in having rather proximal in one area and then the distal in another area. And then of note is that with radiculopathy, pain is actually a common feature. The other term I thought we should discuss is that a plexopathy, which is a disorder of the network of nerves in the brachial or the lumbosacral plexus, which are the two plexus that we have in our bodies. And so in this case, you're going to have multiple nerves that are involved in a single limb, and it's usually asymmetric, and onset is usually painful. There is also rapid onset of the weakness as well as atrophy, and there's also isolated reflex loss. Another classification, which is according to fiber type, is as indicated on this particular slide. So we do have the small fiber neuropathy versus the large fiber neuropathy. Our small fibers, if you remember from physiology, are the A alpha and the C fibers, and our large fibers are the A delta fibers. So there's specific sensations, or rather modalities, that are transmitted in these particular nerve fibers. So for the small fibers, they usually transmit a sensation of temperature and pain, and the large fibers have vibration and proprioception or position sense. And so when a patient presents with a particular pattern of sensory loss or abnormality, you are able to actually identify whether this could be a small fiber neuropathy or a large fiber neuropathy. So of note is that for the small fiber neuropathy, you have pain and paresthesias. You also have autonomic signs and symptoms. Remember, in our preamble, we mentioned that the autonomic nerves actually are the smallest fiber type when it comes to the peripheral nervous system. And other features that you get are temperature loss. There may not be any particular weakness, but usually tendon reflexes tend to be normal. While for the large fiber neuropathy, you have impairment of vibration as well as proprioception. And the common feature is that there's also wasting and weakness of muscles with loss of deep tendon reflexes. This also just further highlights the polyneuropathy classification based on the fiber type, small fiber, large fiber, and then sometimes you can actually have a combination of small and large fiber involved, and then you have global sensory loss as opposed to this isolated pattern of sensory loss based on the fiber type. And then when it comes to the autonomic nerves, which are the smallest type of nerves in the peripheral system, there are some features that can lead to one to suspect that this could actually be a peripheral neuropathy of autonomic type. And these are some of the symptoms that the patient can actually experience. So you can have a postural hypotension, urinary retention, erectile dysfunction. You can also have GI symptoms such as diarrhea and constipation, diminished sweating, impaired pupillary response, cardiac arrhythmias, vascular color changes. So in a case that you're seeing a patient and they have some of these symptoms, you might want to also consider a peripheral neuropathy of the autonomic type in consideration. And this table just shows that various etiology classification, and I particularly chose this table because in as much as it shows various etiologies of peripheral neuropathy, it also sort of classifies them based on the fiber type. So it would be a very good table to go through and just familiarize yourselves with the different causes of peripheral neuropathy based on the fiber type as well. The other classification we discussed earlier was that it could be classified based on the pathophysiology process or the disease process that is causing the peripheral neuropathy. And the broad classification for this is whether it could be an axonal neuropathy or a demyelinating neuropathy. So in an axonal neuropathy, the symptoms and signs are actually related to axon loss. So if you remember the structure of a neuron, you have the cell body, then you have an axon, and some of these axons are myelinated. So when there's damage to the axon and you have axon loss, so that is termed an axonal neuropathy. So because there's damage to the axon, the result is that there's reduced number of neurons. And as a result, the nerve fibers send a weaker signal. Typically for axonal neuropathies, the sensory nerves are affected first as opposed to the motor nerves. And so as a result, most of the symptoms that the patient presents with earlier are those of numbness, pain, pins and needles, mostly sensory symptoms. The axonal neuropathies also tend to affect the longer nerves first. And so the pattern of presentation is that you start to see patients present with symptoms in the more distal part of their limbs, and this progresses proximally. We mentioned that it affects sensory fibers before motor nerve fibers, and the longer fibers, we know they innervate the legs. So commonly, the patients will present with sensory symptoms in their feet and their legs as well. The hands are also involved, especially once the neuropathy is sort of above the level of the knees. That's in a typical case, but that might not always be the case. You can have involvement of the hands a bit earlier than that. And then also of note is that actually the majority of neuropathy that is encountered is axonal. For the demyelinating neuropathy, so these ones produce abnormalities because of impaired interaction between the Schwann cells and their axons. So remember, the Schwann cells are the ones that produce the myelin that surrounds the axons. And so when there's impaired interaction between the Schwann cells and the axons, there's a poor myelination, or when there's damage to the myelin sheath, there's also demyelinating, and this can result in a demyelinating neuropathy. The result of this is that there's slowed nerve conduction velocity. So remember, the myelinated nerve cells are the ones that transmit impulses faster than the unmyelinated cells. So when there's demyelination, there's nerve conduction velocity that is very slow. And in the case of demyelinating neuropathy, the large nerves are usually typically affected first, and these are the motor nerves that we discussed earlier on. So the typical presentation for a demyelinating neuropathy would be that of a weakness more than sensory symptoms. Although eventually patients, most of them will actually complain of sensory symptoms a little later. Again, based on the anatomic pattern, you can have causes that are specific to a demyelinating and causes that are specific to an axonal neuropathy. And then this table also includes a neuronal neuropathy that is when the cell body is also involved. In terms of time course, so you can have a neuropathy that presents acutely and, over maybe hours to days. And the common causes of these are actually the inflammatory conditions like GBS, toxic exposure, and other causes that are listed in this table. You can also have peripheral neuropathies that present in a subacute manner, meaning over days to weeks. And most of these are also inflammatory, but you can also have toxic as well as nutritional and causes, as well as peripheral neuropathy that is associated with alcohol overuse. And then for the chronic causes, they are also listed down there, and this can occur over longer periods, taking months to and actually years. So time course is another way we can classify the type of peripheral neuropathy an individual might have. And then in terms of etiological classification, so there's quite a number of causes of peripheral neuropathy. And this table, or rather this slide, just lists some of the common ones and classified as whether they're metabolic, infectious, there could be autoimmune, there could be hereditary or exposure to toxins, could be also a vasculitis or paraneoplastic manifestation, especially for lung malignancy, but other malignancies as well, like multiple myeloma and other hematological malignancies have a tendency to actually cause peripheral neuropathy. And it could also be nutritional as well. So for diagnostic clues, so when you're getting a history, it's very important to pay particular attention to certain details that can help you determine what type of peripheral neuropathy the patient has, and also the possible etiology of the peripheral neuropathy. So we have discussed some symptoms, which I will not go through. These could be sensory symptoms, could be motor symptoms, could also be autonomic symptoms. The course then is important to take a history of how the course of the development of symptoms were as well. Was it acute, was it subacute, or it was a chronic course? So in the case of acute onset with most severe symptoms, I mean the peak of symptoms being at the onset, you think of things such as trauma or ischemia. And often when it's ischemia, there's pain as a prominent feature. In cases of subacute course, which extends over days to weeks, you'd want to think of something that's more metabolic or inflammatory neuropathies. And then in the case of a chronic course that happens over weeks to months, you'd want to think more of something toxic or metabolic neuropathy. For the chronic course, you can also have those that are slowly progressive, and they occur over many years. And mostly these are hereditary, but also you can think of other etiologies such as CIDP. And then you can also have a course of symptoms which is relapsing, and which offers a relapsing and a remitting course. And we have particular etiologies that are quite specific to this particular pattern of presentation, including CIDP, porphyria, some hereditary neuropathies, Refsum's disease, and if a patient has repeated exposure to a toxin. And still on the history, we'd also want to get a thorough past medical history, because remember we mentioned there are certain systemic diseases that can be associated with neuropathies. So you are thinking of conditions such as hypothyroidism, diabetes. You would also want to know what the patient's HIV status is. You would also want to know what their diet is as well, because we have nutritional causes for peripheral neuropathy, such as B12 deficiency. You would also want to know if they're using any vitamins, especially B6. You would also want to know, especially in certain regions, if there was a possibility of a tick bite, because you'd want to find out if there's Lyme disease that can cause a peripheral neuropathy. And you'd also want to ask about constitutional symptoms, just to rule out any possibility of a malignancy. When examining the patient, you might also have some clues. And so you want to do a full neurological and systemic exam, include the cranial nerve examinations, because this might provide evidence of a mononeuropathy that is from one of the cranial nerves. So that one should not be excluded. You might also want to include the fundoscopy exam, because fundoscopy may show certain abnormalities like optic pallor, which can give clues to the possibility of having a leukodystrophy or B12 deficiency. And then examination and palpation of certain areas where nerves can palpate can actually give away thickened nerves. And then also in your exam include to monitor the heart rate, check for any variability. You can also do the Valsalva maneuvers and check your BPs and see if there are any changes, as well as the pulse. And this can give you a guide to the possibility of autonomic dysfunction. Some other tests that you can do for autonomic dysfunction include the QSART, that is like a test the autonomic nerves that are responsible for control of sweating. And so you're exposed to certain environments to see if there'll be any changes in that particular function. And this can aid to determining whether there's autonomic dysfunction or not. In terms of diagnosis, so the diagnosis of peripheral neuropathy is largely clinical, based on your history and examination. So you get to know what the pattern of symptom presentation is, the time course, any underlying systemic illnesses or medical conditions that the patient has. But we do have tests that can help to support your diagnosis, and these can be laboratory tests, various imaging, electrophysiology studies, as well as histopathology. So in terms of lab diagnosis or investigations, rather, we have a panel of blood tests that can be done, and most of these are to basically rule out any underlying infections or other medical conditions that can cause peripheral neuropathy. So HbA1c to help diagnose diabetes, urea and electrolytes for renal dysfunction, LFTs, because both of these can actually cause a peripheral neuropathy. The uremia can cause peripheral neuropathy, but also impaired liver function can also result in peripheral neuropathy. Other investigations include thyroid function tests. In the case of hypothyroidism, vitamin B12, RPR in terms of syphilis. You can also do an autoimmune screening because you can have certain autoimmune conditions and certain vasculitis that can also present with peripheral neuropathies. In the case of suspected multiple myeloma, you want to do your serum protein electrophoresis. And then in cases of hereditary conditions, you might, if you are able to do a DNA analysis. Apart from blood tests, you can also do urine tests. So you can check for your Best-Jones protein. You can also check for porphyria and as well as heavy metals that can cause a peripheral neuropathy. So you can also do CSF studies, and these are warranted, especially when there's suspicion of an inflammatory or vasculitic or paraneoplastic, as well as an infectious cause. You can actually do CSF studies to just aid in diagnosing these conditions. So you can also do imaging. Again, this imaging is mostly to identify any underlying cause. So you can do a chest X-ray just to check for any lung pathology, because we suspect that the patient might have maybe a lung fear that can cause a paraneoplastic syndrome in the form of a peripheral neuropathy. You can also use other modalities like CT chest as well. And then you can also do a skeletal survey that can also help determine if there is a presence of multiple myeloma and other malignancies that can be determined by the skeletal survey. And then you can also do ultrasounds. Apart from determining malignancies, you can also do ultrasound of the nerves, and this can help to identify nerve entrapments, certain tumors, as well as trauma. So the ultrasound can help to identify nerve entrapments, tumors, any trauma or inflammation. And you can actually further do an MRI, and this can help to delineate the site of the disease, to assess the severity and help monitor progress to therapy. In terms of electrophysiology studies, basically these are our nerve conduction studies as well as the EMG studies. So the nerve conduction studies will help confirm the presence of a neuropathy. They also help to locate any focal nerve lesions, especially in cases of mononeuropathy or mononeuritis multiplex. They can also further help identify what the nature of the underlying pathology is. So is this something that's axonal or demyelinating based on the information that you get as you're doing the nerve conduction studies? So for those axonal peripheral neuropathies, usually what is seen are low amplitudes. Like we mentioned, there's damage to the axon, so there's very low amplitude. And then for the demyelinating, because there's slow transmission, what you tend to get is actually you get to see a slow velocity. A nerve biopsy is also another investigation that can be attempted to be done when investigating for peripheral neuropathy. It's not routinely done. There are specific indications when one would want to do a nerve biopsy. But in a case that it's actually indicated, the pseudo nerve is most commonly selected for easy accessibility. But another nerve that could be an alternative is the superficial peroneal nerve. And the beauty of using the superficial peroneal nerve is that it has this added advantage of allowing simultaneous biopsy of the muscles around it through the same incision that is used to do the nerve biopsy. And so you have this combined nerve and muscle biopsy procedure and it increases the yield of identifying a suspected vasculitis. In certain cases, you can also do a skin biopsy. So for patients who are symptomatic with suspected polyneuropathy, you might consider doing a skin biopsy to help diagnose the presence of a polyneuropathy. In terms of treatment, so treatment for peripheral neuropathy will first address the condition's underlying causes. So we discussed, especially for the systemic illnesses such as diabetes. So if someone has a diabetic polyneuropathy, you would want to institute a number of lifestyle changes as well as treatment for the diabetes and make sure that there's good control. And this applies for any other infectious, inflammatory, malignant state that the patient might actually have. Would want to treat the underlying cause because that is what is bringing about the peripheral or causing the peripheral neuropathy. Otherwise, when it comes to treatment, it's mostly symptomatic to help improve symptoms, especially the sensory symptoms. So there's a variety of drugs that are used for symptomatic treatment of peripheral neuropathy, and mostly, even in our setting, we tend to use tricyclic antidepressants such as amitriptyline. We also have calcium channel alpha-2 delta ligands like gabapentin, pregabalin. We can also have serotonin receptor inhibitors like venlafaxine, as well as some topical agents that other people can get, including lidocaine. You also have anti-epileptic drugs like carbamazepine, selective serotonin receptor inhibitors can also be used. You can have opioid analgesics like tramadol and other options such as botulinum toxin in cases of extreme peripheral neuropathy can also be used. Other treatment is mostly supportive, so you would want to, for those that have severe form of disease, you might want them to undergo physical therapy. So physiotherapy becomes very important in this case. You have assistive devices that in various forms that can be used in their homes just to help them with the symptoms that are brought about because of the peripheral neuropathy, especially when they have weakness. So you might want to have certain assistive devices to help them move on with their daily activities. We also want to ensure they have a safe environment. Remember, sometimes the peripheral neuropathy might be severe and they can lose sensation in their limbs, and so they are prone to injury. So you'd want to ensure a safe environment as well as having footwear at all times, as well as good foot hygiene so that in case of infection exposure, they might not really get severe infection. So, so in terms of the prognosis of peripheral neuropathy, a third of cases have an identifiable cause and are treatable. And then the second third of cases is identified, however, not amendable to treatment. And then you have the last third of cases where you don't identify what the cause is. So in summary, it's important that when you are approached with a patient that you suspect has a peripheral neuropathy, you would want to consider the following things to help you determine what type of peripheral neuropathy they have and what the possible etiology is. So when you are taking your history and you're examining, think about which system is involved. Is it motor, sensory, or autonomic, or there are combinations? And then what's the distribution of the weakness? Is it distal versus proximal? Is it proximal and distal? Is it something that's focal? Is it asymmetrical or it's symmetrical? You'd also want, if in case of sensory symptoms, you'd want to know the nature of the sensory involvement. Is this something that's just pain or it's burning or perceptive loss? And all these, as we have discussed during the lecture, will help you to decide the type of peripheral neuropathy, but also ascertain what the cause is. You'd also want to know, is there any evidence of upper motor neuron involvement? So this will sort of change your diagnosis, I mean, is because mostly the upper motor neuron features will be a guide towards more of a central nervous system pathology than a peripheral nervous system. And then we also discussed the time course. So what is the temporal evolution? Is it something that was of acute onset, subacute, or chronic? Any family history of similar symptoms that would be suggestive for a hereditary neuropathy, any skeletal deformities. This can help you determine if there's some conditions like multiple myeloma, and then also any, yeah. Thank you very much. Hope you were able to understand the lecture. Thank you.